Neonatal and Pediatric Pulmonary Hypertension by Associate Professor Dr. Hanan Zekri. This is the most common causes of neonatal pulmonary hypertension in pediatrics. Most probably they are secondary to lung causes like TTN, congenital pneumonias, meconium aspiration, respiratory distress syndrome or air leaks, congenital diaphragmatic hernias, maternal infection, asphyxia or acidosis. This causes pulmonary hypoxic vasoconstriction with elevated pulmonary arterial blood pressure, leading to decreased pulmonary blood flow and right to left shunting across the patent foramen ovale and the PCA. The most common causes are, it might be an idiopathic cause, abnormal transition at birth due to perinatal asphyxia, RDS, or transient tachypnea of the newborn, resulting in impaired pulmonary vasodilation at birth. Parenchymal disorders, such as due to meconium aspiration syndrome or pneumonia. Abnormal lung development, pulmonary hypoplasia due to oligohydramnios secondary to renal dysfunction or anomalies, or prolonged rupture of membranes or congenital diaphragmatic hernias and other pulmonary malformations. It might be due to polycythemia, which causes intravascular obstruction due to hyperviscosity, or pulmonary hypertension in preterm infants, which is probably due to RDS and underdevelopment of the lungs. A rare cause is the pulmonary venous hypertension, which might be caused due to congenital heart diseases. This is another diagram which shows the causes of the neonatal pulmonary hypertension. How to differential diagnose the causes of hypoxemia in newborn infants. We have three differential diagnoses: lung disease with PPHN with pulmonary hypertension, or cyanotic congenital heart disease, or persistent pulmonary hypertension of the neonates without lung causes. From the history, with lung disease without pulmonary hypertension, we have fetal distress, premature rupture of membranes, chorioamnionitis, or any sign of infection, maternal infection. The respiratory distress is present with cases of lung disease. The oxygen saturation on pulse oximetry improves with supplementation of oxygen. With the hyperoxia test, which is a must in all cases of neonatal hypoxemia, we have to do the hyperoxia test. We find that with cases of lung disease, the oxygen saturation increases with hyperoxia test, and the partial pressure of oxygen in the ABG increases to more than 150 millimeters mercury. The CO2 in the ABG, it might be elevated. With hyperoxia and hyperventilation, we have increased in the oxygen saturation. With chest x-rays, it might show the cause and is abnormal. Echocardiogram is normal. With the cyanotic congenital heart disease, we might have an antenatal diagnosis with the fetal echocardiography, or with the respiratory distress. It is not always present in all cases of cyanotic congenital heart disease. Oxygen saturation on pulse oximetry is almost decreased, with no improvement or minimal improvement with oxygen supplementation. Hyperoxia test is negative. The baby is not responding well with a hyperoxia test, and the partial oxygen pressure in the ABG is almost below than 100 millimeters mercury. CO2 might be normal or low due to metabolic acidosis. Hyperoxygenation and hyperventilation, the oxygen saturation, it doesn't rise. Chest x-ray may be abnormal heart contouring, and we might have decreased pulmonary vasculature if it is due to pulmonary atresia or tricuspid atresia or etc. Echocardiogram, it might show the cause of the neonatal hypoxemia, and it is diagnostic for this case. The cases of persistent pulmonary hypertension, from the history, it's almost insignificant with no causes. Respiratory stress is often present. Oxygen saturation is labile, almost labile and decreased. We might have differential cyanosis due to patent ductus arteriosus, which supplies the lower part of the body, so we have difference in the saturation between the upper and lower limbs. It might go up to more than 10 millimeters mercury. Hyperoxia test elevates the saturation more than 100 millimeters mercury. CO2 might be normal or decreased according to the situation of the baby. If there is metabolic acidosis, most probably there is wash of the CO2. With the hyperoxygenation and hyperventilation, the baby improves. Chest x-ray, we might have decreased vascularity. Echocardiogram, we have a normal heart in the echocardiogram, but we have signs of pulmonary hypertension during echocardiography. Okay. Hyperoxia test, I have to stress that it has to be done with endotracheal intubation of the baby and having supplementation of 100% oxygen or more by ambobagging or by new puff or whatever. The most common steps of treatment of neonatal hypertension, the most important thing is oxygenation or hyperoxygenation, which is the most important agent in the treatment of pulmonary hypertension is oxygenation. Then we have to sedate the patient and decrease the stress, because stress increases the stress hormone release, and this causes more and more pulmonary vasoconstriction. We have to elevate or optimize the blood glucose of the patient. Hypoglycemia causes more stress. Intubation might be needed, or high frequency ventilation. Maybe we need surfactant therapy if there is RDS or severe congenital pneumonia. Neuromuscular paralysis if the patient is agitated and is fighting the ventilator. Vasopressors and inotropic support if the patient is hypotensive. Nitric oxide, sildenafil, we can use it as an adjuvant agent to vasodilate the pulmonary vessels to decrease the pulmonary artery pressure, which is elevated. Steroids are debatable. We might need them to elevate the systemic blood pressure if the patients are hypotensive, and it might be needed to decrease the respiratory distress symptoms in patients with the respiratory distress syndrome as a part of the treatment of respiratory distress syndrome and severe respiratory distress. This is diagram showing the most common steps in the management of pulmonary hypertension. We have to sedate the patient, we have to hyperoxygenate him, minimal stimulation, surfactant might be needed. We have to monitor the patient with blood pressure monitoring and ABG frequently. We have to optimize his metabolic acidosis and his blood pressure. We might need high frequency ventilation as seen in the diagram. This is an algorithm to show the drugs of choice and the management choices in each case of pulmonary hypertension in the neonates. We have to do first an echocardiogram. If there is no structural heart disease and pulmonary hypertension is confirmed, we have to assess the blood pressure and cardiac function of each patient, and then we have to choose the proper management of each criteria of each category. Lung recruitment with optimal with optimal ventilatory settings plus or minus surfactant might be needed. If we have normal blood pressure and good cardiac function, oxygenation is mandatory to avoid hypoxia and normalize pH and CO2 in the blood gases. We might need inhaled nitric oxide. If it is not available, we might use inhaled prostaglandins or sildenafil IV form or per oral or nasogastric tube. If there is normal blood pressure and cardiac dysfunction, milrinone is the drug of choice to optimize and elevate the cardiac functions and also vasodilate the pulmonary vessels which are vasoconstricted. If there is low blood pressure and good cardiac function, we might need fluid boluses to optimize the blood pressure. Inotropic support like dopamine, norepinephrine or vasopressin, and then we add oxygenation, inhaled nitric oxide, or plus or minus hydrocortisone if the patient is not responding well to elevate his blood pressure. If there is low blood pressure and cardiac dysfunction also, this is the most critical situation. With rapid deterioration, we have to go through high frequency ventilation or ECMO. A high frequency ventilation it might increase the hypotension and exaggerate it, so ECMO is the choice of management which is not available in every center here in Egypt. Then we have to give fluid boluses. We have to give vasopressors like dopamine, epinephrine, vasopressin, dobutamine, and plus or minus hydrocortisone. Milrinone is indicated to improve the cardiac function and also vasodilate the pulmonary vessels. This is an algorithm which might help us to choose the drugs in each patient and not to use all the drugs at the same time for each patient, because we might not need all these measures in each patient. Okay, this is a diagram that shows the circulation of blood in cases of severe pulmonary hypertension or persistent pulmonary hypertension in the neonates. Here we can see that the blood flow through the patent foramen ovale with elevated right ventricular pressure is right to left shunting. Then the deoxygenated blood goes to the left atrium and then to the left ventricle through the mitral valve. Then it goes through the aorta. This is why we see the patients with decreased oxygen saturation. Also, the pulmonary artery pressure is elevated, so the shunting across the PDE is right to left shunting, and then the descending aorta also has deoxygenated blood, so there is almost differential cyanosis in the upper and lower limbs. Upper limbs are slightly elevated saturation than the lower limbs. This is a diagram that shows the normal to the left side. This is the normal circulation or transitional circulation after birth with elevated left ventricular pressure and left atrial pressure. The patent foramen ovale starts to close spontaneously by the flap, and the PDA blood flow is from the aorta to the pulmonary artery, left right shunting, because the aortic pressure is elevated more than the pulmonary artery pressure in this situation. If we have persistent pulmonary hypertension, the reverse of this circulation is present. We have right to left shunting across the patent foramen ovale due to elevated right atrial pressure and right ventricular pressure, and we have right to left shunting across the PDE also due to elevated pulmonary artery pressure more than the aortic pressure. This is also a diagram that shows the different causes of pulmonary hypertension and the different blood flow across the cardiac cycle in this situation. The first one on the left side, the upper quadrant, this is the cases of congenital heart disease that have pulmonary obstruction. So we have elevated RV pressure in cases of critical PS. The shunting across the PFO is right to left, and through the aorta, the aortic pressure is more than the pulmonary pressure. So the aorta supplies the PDA by blood and goes to the pulmonary artery to supply the pulmonary artery and its branches. So this is a duct-dependent pulmonary circulation. On the left side in the lower quadrant, we have the normal circulation that happens after birth, which is the transitional circulation. We have elevated LV pressure more than the RV pressure, and we have closed PFO and left to right shunting across the PDE. On the right quadrant, on the right side, the upper quadrant, we have the PPHN, or the persistent fetal circulation. We have the right ventricular pressure is more elevated than the left ventricular pressure, with the right to left shunting on the PFO and the PDE. In the lower right quadrant, we have the patients with pulmonary hypertension and cardiac dysfunction. If we have decreased LV systolic pressure and decreased proper emptying of the LV during systole, the LA pressure elevates. This causes left to right shunting across the PFO, but with the aortic pressure which is low due to LV dysfunction, we have right to left shunting across the PDA. So we have an elevated saturation in the upper limbs and decreased saturation in the lower limbs. Okay, this is an echocardiography showing four apical view, chamber view, with severe tricuspid regurg seen here across the tricuspid valve, which reflects the pulmonary artery pressure if we measures the jet across the tricuspid valve regurg. This is an echocardiography Doppler measurement of the blood flow across the PDE, which is bidirectional flow. We can see here that below the baseline is the right to left shunting across the PDE, and above the baseline is the left to right shunting across the PDE. How to assess the severity of the hypoxic respiratory failure in pediatrics, or the PPHN? We can assess this by oxygenation index, which is the most common, which is the FiO2 that the patient needs multiplied the mean airway pressure across the ventilator divided by the partial oxygen pressure in the ABG. Severity is categorized according to the results to very severe, which is more than 40, severe 25 to 40, moderate 15 to 25, or mild is below than 15. Another category of assessment is the P/F ratio, is the ratio of the partial pressure of oxygen in the arterial blood to the fractional inspired oxygen concentration. Severity assessment of based on PF ratio. Mild is more than 200 to 300, moderate more than 100 to 200, and severe 100 millimeters mercury. For calculation of oxygenation index and PF ratios, it's preferable to use pre-ductal blood gases, as we said before that the lower limbs might be supplied by the PDA, so we might have decreased saturation in the lower limbs more than the upper limbs, so it's more accurate to have the pre-ductal sample to assess the proper oxygenation of the body. Oxygen saturation index is a non-invasive index of gas exchange and is calculated as follows: mean airway pressure, FI2 below divided by the pre-ductal saturation. Neurodevelopmental outcome in NICU graduates with severe hypertension. Most of the patients have long-term consequences as neurodevelopmental, cognitive, and hearing abnormalities. Thus, it is essential to provide long-term multidisciplinary follow-up after discharge to help those patients to follow and to have rehabilitation later on after NICU admissions. Neurodevelopmental impairment in approximately 25% of infants, and hearing impairment in approximately 23% of the patients. A 7-year follow-up, mortality remains significantly lower in the ECMO group with no increase in disability. This slide is discussing the pulmonary hypertension in pediatric age group and not the neonatal age group. We have a categorization of the pediatric pulmonary hypertension: prenatal or developmental pulmonary hypertensive vascular disease, perinatal pulmonary vascular maladaptation, pediatric cardiovascular disease, bronchopulmonary dysplasia, isolated pediatric pulmonary hypertensive vascular disease, multifactorial pulmonary hypertensive vascular disease, pediatric lung disease, pediatric thromboembolic disease, pediatric hypobaric hypoxic exposure, pediatric pulmonary vascular disease associated with other system disorders. This is a WHO functional classification of hypertension, like the left-sided congestive heart failure classification by the WHO. Class 1 is the patients with pulmonary hypertension but without the resulting limitation of physical activity. Class 2 slight limitation of physical activity. Class 3 in marked limitation of physical activity. They are comfortable at rest but less than ordinary activity causes undue dyspnea or fatigue with chest pain or near syncope. Class 4, which is the patients with inability to carry out any physical activity without symptoms. These patients also manifest signs of right-sided heart failure with dyspnea, and fatigue may even be present at rest. This is a pediatric functional classification according to the age group, because we have different activities during the different age groups of pediatrics, classified from 0 to 6 months, from 6 months to 1 year, 1 to 2 years, and 2 to 5 years, and 5 to 16 years, according to the activity needed in each age group. Workup for causes of pediatric hypertension and the investigations needed for each case according to the suspected causes. For each patient we have to do CBC, full blood count, iron studies, vitamin B and folic acid, electrolytes, BUN and creatinine, liver functions, coagulation profile, hepatitis serology, thyroid functions, CKMB, troponins, cardiac enzymes, and CK, anti-HIV testing, anti-nuclear antibodies for autoimmune diseases, anti-DNA, the rest of the battery of investigations for autoimmune diseases, anticardiolipin and lupus anticoagulants, thrombophilia screenings for cases of increased blood viscosity and suspicion of pulmonary embolization, immunoassay, hemoglobin electrophoresis to exclude cases of sickle cell anemia. Okay. In each patient with suspicion of hypertension, we have a proper history, symptoms, clinical signs, and classification according to the WHO classification, ECG, echocardiogram, lung functions, and chest x-ray. We have to ask about medications, toxins, high altitude, genetic syndromes. We have to exclude heart diseases or parenchymal lung disease. If there is suspicion for this, we have to do him cardiac cath with or acute vasodilator testing. Consider cardiac MRI. If we have unclear cardiac cath results, or if there is life-threatening situation for this, which might not be indicated in the cardiac cath. We have to exclude HIV, portopulmonary hypertension. Consider CT chest, serological markers, liver ultrasound, or polysomnographic testing to exclude sleep apneas or obstructive sleep apneas. Family history, we have to consider genetic causes, so we have to have a proper family history to exclude idiopathic pulmonary artery hypertension in families. This is another table to see or to put the investigations that we have to consider in each patient with pulmonary hypertension. Then we consider the treatment of the pulmonary hypertension in pediatric age group according to the cause. We have to treat the cause first, then we have to give adjuvant therapies like the pulmonary vasodilators and the anticoagulants. We have to stress that we shouldn't routinely be treated with vasoactive agents, including prostanoids or phosphodiesterase inhibitors or endothelin antagonists, unless we have excluded all causes of pulmonary artery hypertension. We limit the use of these agents only to primary causes of pulmonary arterial hypertension or familial causes, which is idiopathic most probably or genetic, and we don't have surgical or medical management for this condition except by using pulmonary vasodilators. High-dose calcium channel blockers are useful in only 5% of idiopathic pulmonary arterial hypertension who are vasoreactive by cardiac cath. Okay. Unfortunately, we abuse the calcium channel blockers in pediatrics, which might lead to excess morbidity and mortality cases. So we have to do cardiac cath first. If there is vasoreactivity of the pulmonary vessels to oxygenation, we can use them, and it only helps in 5% of the cases. The criteria of vasoreactivity have changed. Only those patients whose mean arterial blood pressure falls more than 10 millimeters mercury to less than 40 millimeters mercury with unchanged or increased cardiac output. When challenged with adenosine, nitric oxide are considered vasoreactive. Of these, only half of the patients are responsive to calcium channel blockers in the long term, which means that we have to limit the use of calcium channel blockers to those out to these criteria of patients. We have definitely surgical intervention with cases of pulmonary arterial hypertension pediatrics. Atrial septostomy might release the RV pressure and improve the RV function. Lung transplantation, which cannot be done here in Egypt. Pulmonary thromboendarterectomy in cases of pulmonary thrombosis or embolizations. Prognosis is unfortunately not good. We have 1.357 years survival rates, which is 91% in the first year, 74, 65 and 59 respectively, which means that the survival rate and chances decrease by time. Thank you very much, and sorry for the unclear sounds. Thank you.